It's Dr. N, and we're back again for another Unique Wellness Course System lecture and lesson. Today, we're going to be starting in on gut health with part one of a multi-part series. There's a fair amount of stuff to talk about, but as always, we have to keep things kind of big picture because individual circumstance, of course, always varies. I want to start out by talking about food reactivity just for a moment. Now, this is this is an important part of this discussion. And in fact, I don't think I would ever have a lecture or discussion about what happens in the gut without talking about the effect of food on the gut. But we cover this in a separate lesson. So while it is an important part of this discussion, we have a separate lesson for that. So let's move on and talk about what we will cover in part one today. We're going to talk about the structure and the organization of the gut. Now, this doesn't have much to do with the immune system. But when we look at the sequential process of how the digestive system is put together and how it works, and the different components that fit into different stages, that does have implications for things like, of course, digestion, absorption of nutrients. And there are some factors that do either predispose you to or protect you against things like gut infections, which is the second thing we're going to be talking about today. And we're going to touch on leaky gut. I actually have a link a little bit later for you to watch a video put together by Nature Reviews, which is one of the top biomedical journals that are out there. They've done a fantastic job, a little 6-minute video on the gut mucosa and how all that stuff works. It gives you some great graphics and some great visual representations. Then we're going to talk just a little bit about the brain-gut axis. And this is the relationship between the brain and the gut, and how really the two each one of those can't work without the other one working well. So let's talk about the structure and the organization. The GI system is very organized and it's very sequential, and it's organized in a way so that what happens at the upper end of the system, for example, in the mouth and the stomach, is absolutely necessary for the successful function of the later stages. So if we're going, say, from a top-down perspective, what happens up high affects what happens in the middle, and what happens in the middle affects what happens down below. And each of these different compartments or divisions of the GI system are responsible for different functions. And so step one preps for the next phase, step two, et cetera, et cetera. Here's a nice little graphic, and you can find these pictures. Just go to Google Images and just type in digestive system. You'll see all kinds of different some pencil drawings, some videos, or not videos, sorry, but some high quality graphics, and others are kind of color coded like this so you can see how things are divided. But I just want to give you that general orientation. For all intents and purposes, the GI system is a tube. And it starts up in the mouth. Of course, it ends at the other end. But it goes like this. It goes from the mouth to the esophagus to the stomach to the small intestine, and then into the large intestine. And you'll notice that if this is the abdomen of a person, if you can see my cursor moving on the screen there, the large and the small intestines actually make up the bulk of the intestinal system. And in fact, estimates are that the average adult human intestinal tract is about 9 meters long, or somewhere between, say, 27 and 30 feet. Now, most of that actually is the small intestine. And as I'll show you in just a moment, most of your digestion and absorption happens in the small intestine. So it's pretty important for that part of your GI system to be healthy. So let's break this up and let's talk about these different parts of the tube and talk about how they're organized and what happens in each compartment. And we're going to make this relatively brief because I know that probably what you're thinking in your mind is, well, I want to talk about things like leaky gut and inflammation. We'll get to that in just a moment. But when we look at the sequential organization, of course, digestion and GI function actually starts in the mouth. And to be really technical, it actually starts up in the brain, in your brainstem, in a part of your brain called the pontomedullary reticular system. We'll end up talking about that a little bit later when we talk about the gut-brain axis, and more particularly when we have a session on something called SIBO, or small intestinal bacterial overgrowth. But up in the mouth, the primary functions that the mouth serves for us is in chewing, in mechanically breaking down the food in preparation for chemical digestion. Now, there is a little bit of digestion that happens in the mouth, but most of that is regulated to or relegated to carbohydrates. The saliva that you produce as you're chewing contains some enzymes that starts the process of digesting carbohydrates. Now, you are breaking down things like protein that's in whatever is in your mouth just by the physical act of mastication would be the proper term, but the chewing act will break down big structures like protein. But most of what happens from a chemical digestion standpoint is carbohydrates. Now, once you swallow and food passes into the esophagus, there's really no digestion that happens there. In fact, the esophagus is mostly for transportation. It really doesn't serve much of a function, either in terms of the digestion capacity. Certainly no nutrient absorption happens there, and there's very little immune activity. Even though there are immune cells in your esophagus, can be inflamed. A lot of times we'll see that with either trauma, or we'll see it with, say, esophagitis that's associated with reflux. But the esophagus is not really considered part of the gut-based immune system, and most of that happens towards small intestine and large intestine. But as the food goes down through the esophagus, it passes into the stomach. Now, the stomach is really where the action starts. In the stomach, carbohydrate digestion is largely suspended. And really what happens in the stomach is we get the production of hydrochloric acid, which is triggered by the protein content of your food. Now, I am not against any different dietary approach. So, for example, number one, I don't believe that there's a one-size-fits-all. So I don't think that all people should be meat eaters. I don't think all people should be vegetarians. I do have some preferences, which we've talked about before, especially in terms of starting points, like a good paleo diet. But I do think that people who don't have animal protein in their diet do sacrifice, to a certain extent, hydrochloric acid production. Now, maybe that's a debatable issue, because you could say, well, I'm eating plant-based proteins, and yes, that might give you some hydrochloric acid production, but certainly not to the same extent that a concentrated source of animal or fish protein will do. Nevertheless, it's the protein content of the food that goes into your stomach that triggers the production of hydrochloric acid, that breaks down the protein so that you can absorb the amino acids that are liberated from that. But the other function that the hydrochloric acid serves us is the sterilization of food. And this is a really important thing, because what we know about people who have inadequate hydrochloric acid production is not only do they tend to suffer with protein maldigestion symptoms, I'll cover those in just a moment, but they also tend to acquire infections more readily, because part of hydrochloric acid's role in the gut is not just digestion, it is sterilization, and therefore hydrochloric acid production is part of your immune response, right? So I hope that you don't think that the food you're eating is completely sterile, because no matter how you prepare it or where you source it, no matter how you handle your food, there's still stuff in there that has the potential to infect you. And if you don't have that acidic environment, then of course you have more chances of inoculation. Now, I want to just mention here about digesting protein or maldigestion symptoms. If you have started to shy away from, say, red meat, and you prefer to eat things like chicken and fish because it's easier to digest, or if you've gone away from animal proteins and fish proteins altogether, and you're shifting more towards a plant-based or vegan or vegetarian diet because of digestive issues, that could be a strong indicator that there's a problem. And so instead of just forsaking a large group of, like a food group, like animal proteins, to eat things that are easier to digest, let's try to figure out where the issue and where the problem is with hydrochloric acid production. So little tweaks and little changes like that. Sometimes the feedback that I get from you on how you're handling different types of foods, whether it's proteins or fats or fibrous type foods, can give me a lot of information that can help me tweak and change your protocols to make them more effective. People who do have hydrochloric acid or protein maldigestion issues tend to stay away from those foods, but when they do eat them, if they eat too much at one time, it tends to sit in their stomach like a brick, and it slows their digestion down. Now, when I say too much at one time, for some people who have really bad hydrochloric acid production, it could quite literally be just a few ounces. I'm not talking about sitting down and eating a 12-ounce porterhouse. I'm talking about even smaller, modest amounts that are relative to the deficiency of hydrochloric acid production. Now, without getting too far down a different trail, the common reasons for hydrochloric acid insufficiency, one of the big ones is thyroid issues. This is a very classic and well-known mechanism that people with hypothyroidism don't produce hydrochloric acid as much. Now, does that mean everyone with a thyroid issue has to be on hydrochloric acid? No, it doesn't mean that, but it does mean that we have to ask certain questions, look for certain things. The other thing that quite often ends up in hydrochloric acid insufficiency, one could be an autoimmune issue. You may have heard of an autoimmune anemia called pernicious anemia. This is where the immune system attacks intrinsic factor. This is something that's involved in B12 absorption. But usually when that happens, the immune system also attacks the very specific cells that make hydrochloric acid. These are called parietal cells. So we can see hydrochloric acid insufficiency associated with autoimmunity, with thyroid conditions, and it's a very known mechanism where people who have things like concussions or traumatic head injuries can lose hydrochloric acid production as well. Now, one thing, and I don't have this up here, another thing that the hydrochloric acid or acidification of the gut helps us with is the absorption of certain key nutrients, specifically things like minerals. So we know that we need good hydrochloric acid to absorb iron. So somebody might be iron deficient, not because there's no iron in their diet, but because they're not making stomach acid to create the environment where iron absorption is optimized. And there are some other things that might be compromised there as well. Now, as the stomach is processing the contents, the protein contents of the gut and sterilizing it and creating an optimal environment to absorb your nutrients, as you continue to move food along the tube and your food goes from the stomach into the small intestine, and this process of moving food along is called peristalsis. That's the technical term for it. But when your stomach goes into the beginning of the small intestine, and the small intestine is about 7 meters, 23 feet long. But at the very top where it connects into the stomach, or the stomach connects into the small intestine, there are sensors for the acid level of the food that is going from the stomach to the small intestine that then triggers the release of enzymes that were stored and produced by the pancreas. Now, pancreatic enzymes are responsible for digesting not just protein, but they're involved in digesting carbohydrates and also in digesting fats with lipases or amylases and proteases. But the interesting thing here is that pancreatic release of the enzymes that it's making is partly dependent on whether or not you're making enough hydrochloric acid. And this goes back to what we were saying before about how step 1 prepares for step 2. So you may have somebody who has a pancreatic enzyme deficiency, or at least the symptoms associated with that. Maybe they don't handle fruits and starches. Maybe they just have kind of broad spectrum digestive complaints, and there's no one thing that you can really hang your hat on, so to speak. It may be that they're dealing with a lack of ability to release enzymes that they're capable of making simply because they're not acidifying their stomach, and it's the acid level coming into the small intestine that tells the pancreas to release what it has already made. Now, that's a little bit convoluted, but I want to point out that everything is connected here. Now, even though we do see very specific roles for hydrochloric acid in the gut, once we get into the small intestine, everything gets digested. And so in the small intestine, remember, this is 23 or so feet long. This is where most of your digestion happens. This is where most of your nutrient absorption happens, and different nutrients are absorbed at different stages along that 23-foot course of the small intestine. And when we look at things beyond just the food issue, the bacterial environment of your intestinal system is not symmetrically distributed. Now, this will be an important topic of discussion when we do talk about SIBO, again, small intestinal bacterial overgrowth. But the small intestine has very few bacteria in it, including your probiotics, your good healthy bacteria, in comparison to what we see in the large intestine. It's not completely sterile, not like we would expect to have in the stomach itself, but the small intestine contains very few bacteria in relation to what goes on in the large intestine and in the colon, particularly towards the end. Now, returning to this idea of digestion and absorption, we know that most of the digestive process occurs in the small intestine, and this is where we see the pancreas participating. So the pancreas and the gallbladder, for example, are considered accessory digestion organs. The pancreas makes a broad spectrum of enzymes that get released in the small intestine, again, based on what comes out of the gut and how acidic it is. But the gallbladder releases what's called bile or bile salts, which is part of how we break down fats from our diet to absorb the smaller components of fat. Now, the gallbladder itself doesn't make bile. Bile is actually made in the liver. The gallbladder is just where the bile gets stored and concentrated so that when fat comes down into the small intestine contained from your diet, then it's the fat content that triggers the release of the gallbladder to release its bile, and the fat gets emulsified, it gets broken down, and then other cells in the small intestine can absorb it. But this is where most of the action happens. The small intestine, again, most of the digestion, most of the nutrient absorption happens there. And we have a lot of activity from these accessory organs, the pancreas and the gallbladder, releasing a very broad spectrum of enzymes, as well as the stored bile for fat digestion. Now, as the contents of the food keep getting squeezed down towards the distal end, towards the large intestine, then we pass into the large intestine itself. And the large intestine is only a couple of meters, say about 6 feet long. Remember, the whole intestinal system is about 30 feet, and the end of that, the large intestine and the colon, is just about 6 of that. Now, there's really no digestion happening here. By the time we get into the large intestine environment, this is where most of your bacteria live, and that would be a combination of good bacteria as well as some what we consider bad bacteria as well. And here's a thought for you. Even healthy guts have some bad bacteria, right? It's not just a complete absence of bad bacteria. It's just a very low amount and a very large amount of high amounts of good bacteria. But really no digestion happening here. There's a little bit of nutrient absorption. There's a lot of water absorption that happens in the large intestine. We do get some electrolytes like calcium or chloride. Sodium gets absorbed in the large intestine. A little bit of vitamin K gets absorbed there. But most of this stuff actually, again, happens in the small intestine. So what is the large intestine for? Well, as you can see here on the bottom, your poo is a zoo. And that's a quote that I took from a medical doctor that's involved in probiotic, or what we might call poop research. The vast majority of functions of the large intestine, aside from absorbing water and a few key nutrients, is just to concentrate all the junk and to get it out. It's your elimination route. And so this idea that your poo is a zoo basically says that the vast majority of the content of your bowel movements is actually probiotics. It's actually bacterial. So we want to make sure that this entire environment is working well. Now, so we're focused here again. Let's pull back and look at the big picture. We're talking about the core 4 concepts of a healthy gut, right? And so we're breaking it down between digestion and absorption and looking at that in the context of structure and organization. But we want to move on into other things. Like we want to look at the intestinal mucosal system, the concepts related to leaky gut, and we want to look at this relationship between gut and brain function. But this is just your big picture of how things are organized and where stuff happens and when. Now let's move on to gut infections. Now, gut infections are discouraged, as we just mentioned, by having adequate stomach acidity. So if you've got something that's compromising hydrochloric acid production, you are more susceptible to being infected by the things that are harbored or hidden within the food that you're eating. Now, gut infections are also discouraged by an intact and functional intestinal lining. So if you've listened to other videos where we've talked about the immune system or specifically autoimmunity, that may or may not be your issue, and you may or may not have seen that particular lesson. But the lining of your intestinal system is really immune tissue. And you could really pose a very good argument that the gut actually is as much immune functionality as it is digestion absorption. And you could even go so far as to say that it's really neurological, because there is a fully intact, what we call second brain. It's called the enteric nervous system. And the gut has its own nervous system. And in fact, the research tells us that there are more neurons or neurological tissue in the gut than you have in your brain. So my question to you is this: is the gut digestive and absorptive, or is it immunological, or is it neurological? And the answer is yes, it's all of that. It's very difficult to separate these things out. But nevertheless, you may have heard before that about 70% of your immune system is in the lining of your gut, and that is absolutely true. And so the lining of the gut does many different things. Number one, it acts like a highly selective filtration system that prevents absorption of things into the bloodstream that should be excluded, concentrated in the large intestine and then eliminated. And that would include things like bacteria or toxins or other things that just really have no business being inside your bloodstream at all. So when we look at the intestinal lining, there are functions related to filtration, but also there are functions related to preventing infections. Embedded inside the lining of your gut is a very important molecule. In fact, this is probably the most abundant antibody produced by your immune system. And it's called secretory IgA, or it's abbreviated SIG-A. SIG-A is how we pronounce that. And SIG-A is a molecule that sits in the lining of the gut that when stuff comes into the gut environment, say the large intestine, because most of this happens there, the SIG-A binds to and neutralizes critters and toxins to prevent them from being absorbed. Even if you have a non-intact or a leaky gut would be a better way to say it. Let's say you have a leaky gut and you've lost that filtration capacity. If you have good secretory IgA capacity, you can compensate by effectively binding and neutralizing things so that they don't get absorbed. And this is an important part of regulating immune systems and reactions within the gut. As long as you have good intact secretory IgA, you tend to have better gut immune responses. Now, unfortunately, a lot of things can compromise your SIG-A production and your SIG-A efficiency. Things like chronic stress and inflammation and always eating foods that you're reacting to, and even hormonal imbalances, whether it's insulin dysregulation or reproductive hormones or thyroid issues, these have all been associated in the medical literature with lower secretory IgA production, which means you end up compromising your ability to not be infected. Now, there's a whole host of other immune factors which we're not going to go into because I don't want to make this too complicated. But the big picture is if you don't want to be infected, you've got to have good stomach acidity. You've got to have an intact, healthy gut environment in the bigger picture, including a good lining, and we'll talk about leaky gut in a moment, and good secretory IgA function. Now, the other thing that's important is good gut motility. Right? We need to have good peristalsis, which means we need to be going to the bathroom on a daily basis, maybe even better a couple of times a day. I have to tell you a very quick and sadly humorous story. Several years ago, I was flipping through a nursing textbook, and this is just, probably, let's say 2013. And I was flipping through this nursing textbook, and it was a brand new textbook just recently published. I wanted to know what they were teaching nurses. And as I was flipping through it, a term at the top of a page caught my eye, and it was called presumed constipation, perceived constipation is what it was called. And as I read that section, perceived constipation was defined in this nursing textbook as the unrealistic expectation that you should have a bowel movement every day. Now, I would propose to you that there's nothing unrealistic about that at all. When you eat, you're putting stuff into a disassembly line. And the expectation is if you're eating food 3 times a day, if you're not eliminating on a daily basis, at some point you are going to be trying to play catch up. And back in the day when I was doing a lot of musculoskeletal medicine and we were doing x-rays of people's backs and pelvic areas because we needed to look at the structure and the mechanics, we would quite often see x-ray evidence of people having their intestines completely impacted all the way up into the small intestine, which, think of it, large intestine is about 2 meters or 6 feet long. That's a lot of poop to be backed up into your system. So, guys, you need to make sure that you're going to the bathroom every day. Now, sometimes it takes time for us to figure out where the lack of motility is coming from and fix that, right? So we need to be patient, but we need to be working towards that. And I want to set the expectation that you should be moving your bowels every single day. And it should be relatively easy, and forgive me for being graphic, it should be copious. Now, let's go back to the motility issue. If you have bad motility, for whatever reason, there's many different reasons that can cause it. Slow motility allows things to brew and stew. And it's a yucky thing to think about, but if you're not moving your bowels every single day, whatever is still in your intestinal system that hasn't been completely taken care of or neutralized has the chance to brew and stew, and it can start growing and overpopulating. And this is a real issue. So the ability to fend off infections is multifactorial. You got to have good stomach acid. You've got to have a good intact intestinal lining system to be able to filter out things, bind them and neutralize them, create localized gut responses that take care of the infections, and then you need to get stuff out every single day, right? That's the big picture. Now, when it comes to infections, there are many different companies out there that will take your money and examine your poop and tell you what's in there. Unfortunately, conventional testing is completely inadequate. Let me tell you why. It's not because the people designing the tests are not intelligent or the ones doing the testing are inadequately trained. It's very simple, a matter of perspective. In the conventional system, and that this could be just your GP, your internist, or a gastroenterologist, their primary focus and concern is on acute and not chronic infections. And so when they order a stool test that you might do through, say, Quest or LabCorp, they invariably order maybe 4 or 5 or 6 different organisms, and they could be some bacteria, maybe some viruses, and certainly some parasites that are known to cause acute gastritis or diarrhea. That's really the issue. So I have every once in a while clients will come into my office and we'll do a consultation to see if we want to work together. And I might say something like, I think we need to do a stool test. And if they say to me, well, I've already done that. My doctor ordered one. My next question is, well, where did you get it done and what did they look for? And usually it's one of their GPs or perhaps a gastroenterologist. And when I look at the report, if they have it there, sure enough, they've only done 3 or 4 or 5 or 6 different acute critters, and that has very little to do with the chronic setting. But here's the fundamental problem. If I run a test that looks for 5 critters and it comes back negative, I can't tell you that you're not infected. I can just tell you that you don't have the 5 things that we looked for. Now, realistically, how many critters are out there do you think can be an infection for you? Well, hundreds, if not thousands, if not more, because there's certainly things out there that we don't even know about. So the conventional testing methodology, the perspective and the mindset is really kind of faulty for what we need to do, and most of our clients have chronic issues. Now, there are many specialty labs that will do a better job because they look for more things, but I'll tell you that even specialty testing is hit and miss. And I've probably said to you before in different lessons that every single testing methodology, including just simple blood testing, has a margin of error, and there's a little bit of hit and miss involved here. And so when you look at the research on looking at stool sampling, even multiple samples can miss things. And without getting too graphic, every year I have 3 or 4 people who text me, sometimes send me a picture saying, "Doc, there's things, little wiggly things moving around in the stool and in the toilet, and we ran a stool test and it didn't show anything." And that just undergirds the fact that, every test is going to miss something. And unfortunately, things like parasites and even fungal infections are notoriously difficult to find with lab testing. Now, most of these specialty labs try to compensate by doing some kind of a combination of microscopic exam, meaning that they're actually literally looking at a sample through a microscope. And then they may do some versions of chemical testing looking for antibodies to certain types of critters. But, the bottom line is you only have a certain menu of things to choose from, and every single bit of technology has some limitations. And this type of exam, especially the microscopic exam, is heavily tech dependent, meaning that you have to have a tech that's trained well enough to see something in the stool and to be able to visibly identify what that particular thing is. And ultimately testing is only as good as the people that design and run the test, as well as the quality of the testing materials themselves. And most labs are sourcing the materials that they use to run their test by other companies. And there's a whole science behind that quite honestly, I am not equipped to explain because it's not my expertise. But thankfully, I do know people who are experts in that. And we've had several discussions about how this is a limiting factor in some cases. Also, many labs have add-on tests that really are more flash than anything else. And I will be completely honest that I have been guilty in the past of doing these tests because of all these flashy add-ons up until the point where I realized, hey, this is just a flashy add-on. It really doesn't help me. So let me give you an example. A lot of the high-profile specialty labs, and I'm not going to name anyone, but a lot of these high-profile labs will give you markers for digestion, markers that theoretically tell you whether or not you're making enough hydrochloric acid or whether or not you're making enough pancreatic enzymes. But the truth is that these digestion markers vary from bowel movement to bowel movement. They vary from day to day. And so I may get one test that says, hey, you're doing great on hydrochloric acid today, but do it tomorrow and it looks like you're not digesting your proteins at all. So that really doesn't help us when it's not consistent over time. And a lot of labs these days are doing probiotic assessments, and that's a good thing for us to do, in my opinion. But the problem is that we're not really recognizing that we're measuring a very, very small piece of a very large unknown. There are thousands and thousands of known probiotic species. Now, we don't know how many unknowns there are because we don't know. And the labs can only measure a handful. And so to think that a lab is going to give us a report and it's going to tell us exactly what's going on with our probiotic environment is actually clinically naive. Have I made that mistake? Yes. But then I continue to study, learn, talk to the experts, and then you make better decisions in terms of doing tests and which one you choose. Now, as of right now, the best technology is actually DNA-based. DNA-based technology really kind of eliminates the tech-dependent errors that we would see with, say, microscopic exams and some of the other technology limitations. By doing DNA-based testing, it's about 1,000 times more sensitive, meaning it's way more effective at finding things than any other test that existed prior to the DNA technology getting to the level where we can use it clinically. Now, having said that, it's still going to miss some stuff, and it's going to miss things it doesn't test for. So the lab that we are using as of when we're recording this really only tests for a couple of dozen things. Well, what happens if you have something that's not on that list? Well, the test is going to miss it. So we need to make sure that if we are doing a stool test in your program, I'll come back to that idea in a second, that we're interpreting the data appropriately. Because you may have a completely negative test result, it does not mean you're not infected. It just means that within a reasonable certainty, you don't have what we looked for. Now, the question then remains is, are we doing a test or are we not? And if so, why or why not? Well, quite honestly, sometimes we don't do testing because we're pretty convinced based on history, based on how we see things behaving over time, that there is an infection there. Now, if we do decide to not run a stool test up front, we almost always require a test at the end of a gut protocol just to make sure that we've done what we thought we should do. So there are some circumstances where I feel it is clinically relevant and necessary to do a test up front. Sometimes I'm okay making an assumption that there's nothing going, or that there is something going on and we should just treat it as if. And sometimes it's my client who says, no, doc, I want to see the report, right? I just want to see the results. And so sometimes we'll order that test just based on the client request. But invariably, if I were to say to you over the past, let me go back even close to 10 years, the vast majority of stool tests that I have run in the beginning of a program were positive. They found something. So over time, you start developing this, I guess, clinically realistic expectation that most of the clients we work with are infected. Now, does that mean that the average person walking around is infected? No, because my opinion is biased based on the type of people we work with. If we were to take a random sample of completely healthy, asymptomatic people, we'd find a lot of people have no infections. But we work with people who have complaints. Some people have gut complaints, some don't. And here's my final point. On the bottom there, it says 80% of this guy called H. pylori, these are asymptomatic infections. Now, H. pylori is a bacteria, and it's probably best known as being involved in a lot of cases of gastric ulcers. And H. pylori, years ago, I haven't checked the statistic recently, but years ago, H. pylori was indicated by the World Health Organization and the CDC as the most common infectious disease in the world. About 50% of the world's population at any given time has this infection, but 80% of the people with this infection are asymptomatic. Now, there's a connection between H. pylori and stomach ulcers. There's also a connection between H. pylori, chronic gut inflammation, and over time, the development of inflammatory bowel disorders and even worse, stomach cancer. But it's largely asymptomatic. And so I may, from time to time, tell somebody, hey, you need to have a stool test. And they may go, well, why? I don't have any gut symptoms. Honestly, I don't care, because that's not the decision point. The decision point is whether or not we're going to do everything we can to try to figure out what the issues are and find things that we can fix, a lot of people that are infected have no gut symptoms. They have no gas, they have no bloating, they have no indigestion, and maybe even their bowel motility is working well. That does not mean that you're not infected. So, as I'm recording this and you're listening, I don't know if we're doing a stool test in your program or not, but I want you to know that we don't do stool testing in everybody. We don't not do stool testing in everybody, but whatever choice we make that for specific reasons, and it's usually a mutual decision, right? But we want to make sure that we're using the right technology and we're interpreting things the right way. Now, what about the different types of infections that we can find? Well, we've already talked about acute versus chronic, right? Acute infections typically resolve. I remember back when I was in my early 20s, I had a nasty day, 24 hours, literally, actually 13 hours, with food poisoning. I had had some chicken wings for lunch one day that were not cooked well, and 13 hours later, I was in the emergency room. Worst day of my life that I can remember. And within about 13 to 24 hours after that, it was gone. And so we understand that acute infections behave one way and chronic infections behave a very different way. So if we have people with chronic health complaints, we can't necessarily look for things that are commonly involved in acute infections, and that's where the conventional system places most of their focus. Now, what about other kinds of infections? Well, it's very interesting, and I'll just put these up here. We can have bacterial, fungal, parasitic, or viral infections in the gut. And they can hit you in different ways. They can be asymptomatic, or they can produce different types of symptoms. There is a lot of overlap, and you can have more than one kind of infection, right? So it's not unusual to find a bacteria and say candida as a fungal infection, or bacteria and parasites, or fungal infections and evidence of a viral issue, or multiple things. The bottom line is, and in our next session, in part 2 of this, we'll be talking about the protocol that we use to get rid of gut infections and to restore health to the gut. That's called the 4R protocol. We'll review that in our next lesson. But I'll tell you that 15 years ago, specifically with things like parasitic infections, we thought that the only people that got parasitic infections were those who visited underprivileged or, say, third world countries. But, we don't have to look anywhere beyond our own borders, so to speak, here in the U.S. to find people that have gut infections, particularly parasitic infections. Now, fungal infections and parasitic infections are notoriously difficult to find with pretty much any technology. I do believe that the DNA technology has an advantage here because we don't have to have as many critters to find evidence. If there are DNA fragments in there, even with just a few, the sensitivity of this testing technology is actually pretty good. But having said that, parasites, and this gets a little bit icky for just a moment here, but parasites and fungal species tend to stick to the lining of the intestinal wall, and they can encase themselves. In fact, bacteria can do this as well. They tend to encase themselves in a gooey matrix, what's called a biofilm. And the gooey matrix just kind of hides them, and it protects them so that if you're taking antibiotics, antifungal medications, or even botanicals and natural stuff, it can't always penetrate that shield, if you will, to kill them. Now, the other problem is that if they're stuck to the intestinal wall and they're encased in this gooey matrix, they're not in the free-flowing stream of stool that ultimately comes out as a stool sample that somebody examines. So you may have nothing in the stool, but you have things stuck to the intestinal wall, interacting with your immune system, creating chemicals that are wreaking havoc on your health and your well-being, but the stool test is negative. On top of that, parasitic species have a 30-day life cycle. And they have two different forms. They have different forms that they exist in. They can be in an adult phase, or they can be in what we call a cystic phase, which is kind of like a dormant egg. And if you're doing your testing when most of your parasites are in that dormant egg phase and they're not replicating in a whole bunch around, you may test today and get nothing, but you may test 3 weeks or a month later and get a whole bunch of stuff. So again, these are some of the reasons why we don't always do stool testing in every single case, but we do a fair amount, right? We do enough that we feel that we know what we're doing with. and we understand enough about GI function and immunology that we feel like we can make the right decisions whether we choose to do a stool test or not to do a stool test. Now, you may be wondering, well, is there a different protocol based on the kind of critter that we have? And the answer is maybe. If you're a conventional doctor, you're going to use antibiotics to kill bacterial infections. If you're a conventional doctor, you're going to use antifungal meds to kill a fungal species like Candida or any of the hundreds, if not thousands, of other species of fungus. If you have a parasitic infection, you're going to use antiparasitic meds, and you may use antivirals for viral type infections. But when you're in the world that I live in, which is we don't really care what kind of problem you have, we're going to use broad spectrum herbal botanicals that are effective against multiple types of species. We don't worry so much about what kind of infection you have, which is why I hope that if you're listening to this and we've decided not to do a stool test but assume that you're infected, we can still be effective because we're going broad spectrum. And the things that we use in clinical practice are effective against bacteria and parasites and fungal species all at the same time. Now, we'll go into more detail when we talk about the 4R protocol in our next session. Now, let's move on to the leaky gut issue. Well, let's deal with the first question, which is it even real? I've been lecturing on leaky gut in the group that I lecture for. We've been talking about this for probably about 8 years now. And the very first lecture I did what I'm showing you here. This is a screenshot from the National Library of Medicine. This is a website called PubMed. And this is where we have a summary and sometimes the full articles of all the research that are appearing in what's called the indexed literature. And those are all the journals that everybody agree are good, high-quality journals with good, high-quality research. And so what I wanted to do is make sure that you understand that leaky gut, and the technical term for that is intestinal permeability. I want you to understand that this is a real thing. If you go to Wikipedia and you type in intestinal permeability, not that Wikipedia is the end-all be-all of information resources, but there are articles there and comments on intestinal permeability or leaky gut that talk about it as if it's something that we've all made up. Now, this is a research result, and this is just a screenshot. You can do this yourself. Go to pubmed.gov, go to the search bar and type in intestinal permeability, and as of 2016, where I'm recording this video, this search result returns almost 12,000 articles that have something to do with intestinal permeability, and I can guarantee you they're not all saying, hey, this doesn't exist. But the hard part is that we have a very low awareness, not just among the general population about leaky gut, what it is, what's the implication, but among practicing clinicians, including gastroenterologists. And in fact, I had 2 clients in the last year that I can think of off the top of my head who took their leaky gut tests to their gastroenterologist after we did their workup. And in one case, it was a lady she'd had a history of chronic diarrhea for 10 years. Can you imagine? 10 years. She'd been working with this guy, and she walks in and she brings all of her documentation from the work that we've done, and she's already doing significantly better, right? She's within 3 weeks of care, her diarrhea had pretty much stopped, completely changed her life. And so she hands all the packet of information to the guy. He's flipping through it, and he gets to the leaky gut test, and he looks at her and he crumples it up and throws it in the garbage can and says, "We don't believe in leaky gut." Now here's the problem. A lot of the research that validates leaky gut as a health issue connected to so many different things comes from gastroenterology journals. So all that tells me is that the specialists that are out there are not even reading their own research. So leaky gut is real. Prove it to yourself if you need to. Just go to PubMed and do a search, and you're going to get probably the exact same number unless you do it 6 months down the road. Because I'll tell you, 5 years ago, the number of research papers published on this issue was just under 9,000. Here we are a few years later, and now we have almost 12. And that means over a period of several years, there have been about 3,000, maybe a little more than that, 3,000 articles published. That's almost 1,000 articles per year on one topic that the specialists in this field are saying this doesn't even exist and somebody's making it up. So that's a real problem. Anyways, it is real. Let's talk about the core features of leaky gut. And there are really kind of 2 things that come along with leaky gut is you get immune activation and you get malabsorption of nutrients. Now, my job here is not to give you all of the minutia. And believe me, with almost 12,000 journal articles, there's a lot of detail that we could go into about leaky gut. My job is to give you that big picture and make sure that you know how to relate this to you if this is an issue. And by the way, this is another area where we either do test or don't. But if we don't test it, we assume that you have it because the cost of assuming you don't have it and being wrong is bad for you, right? So sometimes we do test, sometimes we don't. Again, my experience with the people I work with is almost everyone has a leaky gut, but that does not mean the whole world does. So what are the core features of leaky gut? Well, first of all, we see a breakdown of the intestinal lining, a loss of what are called tight junctions. And I'll show you a graphic in just a moment. It's just a very simple one, but again, all you have to do is go to Google, go to their images and type in leaky gut diagram or picture, and you'll come up with all kinds of representations of what the cells look like. Now, what is a tight junction? Well, imagine, if you will, that the lining of the intestines are just a whole bunch of cells that are jammed up next to each other. And the tighter they are together, the easier it is for them to prevent things from absorbing through the wall of the intestines into the bloodstream. And the tight junctions are not just these cells jam-packed against each other. There are actually cross-linking proteins that connect one cell to the next to keep them together, to prevent them from drifting apart and therefore opening up a space. And that's what's called the tight junction. It's cells jammed up against each other and then connected with protein structures that cross-link. They're called tight junction proteins. Now, when you lose these tight junctions, you lose the ability to keep them jammed up against each other, and so the cells tend to drift apart, and now we have an open channel of entry where things that are in the gut can migrate through the gut lining and absorb into the bloodstream. So we see a failure of filtering and exclusion, and in fact, one of the main functions of the intestinal lining is to act as a selective filter and exclude things from absorption, things like toxins and bacteria and viruses and junk that's going to make you sick and it's going to make you inflamed. Because here's the bottom line. When you lose your tight junctions and you get this leaky gut, you get a localized immune activation, translate that into inflammation, but that inflammation doesn't stay in the gut, it goes systemic. The inflammatory chemicals escape the gut environment, they go into the bloodstream, and these guys know no boundaries. They have a free pass anywhere, including your joints, including your pancreas, including your brain. And a leaky gut leads to systemic inflammation, and that can manifest in different ways for different people, depending on what their other challenges are. Now, if you look at the medical research and look at enough of these almost 12,000 papers, you'll see that leaky gut is connected to almost every major chronic disease and primary health complaint. All of your autoimmune issues. In fact, some researchers suggest that you need to have a leaky gut to trigger an autoimmunity. Other researchers disagree and say, nevertheless, the inflammation from having an autoimmune disease inevitably creates leaky gut. So we almost always see leaky gut issues with clients who have systemic inflammatory problems, including autoimmune disease. But we see leaky gut associated with things like major depression, with anxiety, chronic fatigue, fibromyalgia, type 1 diabetes, congestive heart failure, renal disorders, joint complaints, orthopedic issues, you name it, leaky gut is connected. So it's a big deal. It really truly does exist. And because of the core importance of the intestinal lining and what that means to immune function and control of inflammation, or the ability of the gut to act as part of your barrier system, which is how you prevent things from outside getting to the inside of your body, when that thing fails, bad stuff happens, right? And so it becomes very important for us to either assess it and manage what we find, or to assume that you have it based on reasonable expectation and then manage as if until we can prove at some point that we fixed what we thought was there to begin with. Now, what I'm going to do here is I'm going to pause for a second. In fact, you can pause this video and you can either write down this link, or there should be a link that shows up on the, typically it's up on the right-hand part of this screen, where I'll put a link to this video. The journal Nature and Nature Reviews does a fantastic job of putting together videos that illustrate certain concepts. These are high-quality videos, high-production videos. And this one in particular, which you can either find yourself by using this link on YouTube or click the link that I'll provide for you. It's only 6 minutes long, but it gives you a really good graphic representation of the gut mucosa, how it works, how the immune system interacts with this, how do you get a leaky gut. It gives you a really good stuff. And so if you have a leaky gut, or we think you do, this is what's happening inside of you, right? And this is what we're trying to fix with our diet and lifestyle changes, as well as with what we're doing with our supplementation. So go ahead and make sure you watch that. Now, what about things that cause it? Well, there's any number of things. You can look up on the top here, and it says triggers that cause intestinal damage. Dietary proteins, and these are going to be predominantly foods that you're reacting to, whether it's gluten or dairy or soy or corn or tomatoes or whatever the case might be. You can have it by having maldigestion, right? If you're not breaking things down, you get fermentation, you get stewing and brewing. You can have certain medications like antibiotics. Steroids can do this. Any kind of infection in the gut. The inflammation associated with blood sugar issues. In fact, there's a huge body of research connecting insulin resistance and diabetes to leaky gut, and they tend to feed off each other, so one makes the other worse, which feeds back and makes the other one worse. Hormonal shifts associated with pregnancy and childbirth, menopause, chronic stress, toxins in your food, and we talked about food allergies. These are some of the things that are published in medical research that tend to promote the acquisition of leaky gut. Now, here's a nice little graphic of what these are called epithelial cells. These are the cells that line your gut itself. And you'll notice these cross-linking proteins here that create the tight junction. But when you lose these tight junction proteins, the cells drift apart, and now we have a big open space where junk can get from the gut, go through the lining, and then get up into the bloodstream, which then causes these systemic inflammatory problems. Now, there is a malabsorption problem here as well, which can lead to certain key nutrient deficiencies, because typically with leaky in gut, the cells that are involved in nutrient absorption don't work efficiently. There could also be an abundance of abnormal mucus production, which tends to plug up the tissues and prevent the nutrients from being absorbed the way they should. Now, this one particular version of leaky gut, not to get too technical, because ultimately it doesn't matter whether you have what's called paracellular permeability, which is where things go between two cells, or whether you have destruction of the cells themselves and things go through the cell. This is what's called transcellular permeability. Ultimately, the end result is the same. The treatment of this, or the management, is no different. It is what it is, but I just want you to know that there are actually two versions of leaky gut. You can have one or the other, or both, or none, but if you have either one of these or both, the management approach is the same. We have to find and get rid of the triggers, and then we have to do things to heal the gut environment, right? Now, that can take quite a long time. It can take 4 months or 6 months or 10 months. There's so many different factors that affect the time frame that I can't give you a specific time where everyone is going to be healed. We'll talk more about that when we get to the 4R protocol in part 2. But this should give you a nice visual representation. This plus the nature video should serve you quite well in understanding this idea, this concept. Now, our final topic here is the brain-gut axis. I am not going to go into a ton of detail. Again, this is one of those big, huge topics, which may or may not be an issue for you. But I do want to at least get the simplistic or the big picture out for you. First of all, gut function is controlled by kind of three primary systems. One is a whole bunch of local control factors. And so what goes on in the gut is dependent on whether or not you've got a leaky gut. Are you eating foods you're reacting to? Are you inflamed? Are you making neurotransmitters? Almost all of the neurotransmitters that work in your body are produced in the gut, things like acetylcholine or serotonin. So there are local control factors that affect gut motility, and one of those is that enteric nervous system, that second brain that we had talked about before. And these are very important, but ultimately, outside of the gut environment itself, the two main things that have an influence in how the gut works is the status of your thyroid system. So in cases of low thyroid function, the gut tends to not work well. And the other thing is the relationship that the gut has with the brain. And the term that the medical research uses is called the brain-gut axis. Now, this is something else that hardly any other physician knows about, but go to PubMed.gov and type in brain-gut axis. This is a term that the neuroendocrine immunologists are using to describe the relationship between the gut and the brain. And that's actually a two-way communication. Now, here's what your thyroid and your brain-gut axis affect. The brain-gut axis, and we can include the thyroid here, have a great deal of influence over enzyme secretion, and that includes your hydrochloric acid status, right? Your ability to break down proteins, your ability to sterilize your gut. It also has an impact on your pancreas and your gallbladder to improve global digestion as well as things like fat absorption. Your brain-gut axis and your thyroid have a lot to do with blood flow. And if you can't get blood flow to a leaky gut, you're not going to heal it. So if you have blood flow issues, you tend to break down tissue and you can't heal them. You also see a big impact on gut motility, low thyroid, constipation, head injury, neurodegeneration, constipation. Now, sometimes we see clients that have increased bowel motility, and that's usually due to other things. But the relationship that we typically see with the brain-gut axis has to do with slowing motility down. So we get impaction, we get stewing and brewing, we get fermentation, we get putrefaction of proteins and all kinds of nasty things. And then the other thing that we see the brain-gut axis and the thyroid having some influence over is over valve control. Now, what do I mean by that? Well, when you look at peristalsis and you look at food moving from the mouth to the esophagus, from the esophagus to the stomach, to the small intestine, to the large intestine, and then out again, that's a one-way street. And if there weren't a series of valves that would prevent things from backing up and going in the wrong direction, then we would end up with a bad situation. So for example, at the dividing point between the stomach and the small intestine, there's a valve. It's a sphincter valve. And this closes down to prevent things that have just gone into the small intestine from backing up into the stomach. There's a valve that controls the flow of things from the small intestine to the large intestine. This is called the ileocecal valve. And when things go into the small intestine, that valve closes, or should, and stay closed, to prevent things from backing up into the small intestine. This is part of what fails when we get this SIBO thing that we've mentioned a couple of times. We actually get valve control failure, and we get the inoculation of the small intestine with bacteria from the large intestine, and that is usually a big deal for a lot of people. Now, the brain-gut axis is a very complex thing, right? We've only understood the fundamentals of that for probably the past, say, 5 to 7 years, and it's only now that this stuff is starting to come out in popular media. We're getting some books, and people on the internet are talking about it. Most of your practicing clinicians are not going to know about this. They're not going to know how to assess it, and they're certainly not going to know how to manage it, or I'll use the word treat it. Now, the other thing that the brain-gut axis has is it's got a two-way communication. So it's not just the brain talking to the gut, affecting enzymes, motility, blood flow, and valve control. It also works the other way. There's a gut-brain axis as well, where the gut feeds information back into the brain. Now, part of that is strictly neurological. There are nerve sensors that translate information related to movement, to chemical changes, up through what's called the vagus nerve. It's called the sensory portion of the vagus nerve. And so the gut actually feeds neurological information into your brainstem, so your brain knows what's going on in the gut environment. But aside from that, the gut actually makes compounds that talk to the brain. So the gut makes neuropeptides. These are protein structures made in the gut that go into the bloodstream that affect brain function, specifically in the brainstem. The gut environment also makes hormones that affect the brain. In fact, some of the enzymes, things like cholecystokinin or ghrelin, these are hormones or even enzymes that are made by the gut that affect how the brain works. Beyond that, the probiotics, the healthy bacteria in your gut, make chemicals and compounds that affect the brain. This is a brand new area of research where we're starting to see specific species of good, healthy bacteria making specific chemicals that have a specific effect on specific parts of the brain. And honestly, from a clinical standpoint, that's absolutely crazy, but it is how the system is designed. We just don't know enough about it yet to be very intentional in manipulating those environments. And the other thing where the brain or the gut can affect the brain is in the production of inflammation. As we mentioned earlier, the inflammation that's associated with either eating food that you're reacting to, having a leaky gut, or being infected, that inflammation tends to go systemic, and one of the areas that can have a large impact would be the brain itself. Now, so what we've done so far today is we've talked about the gut as a general kind of a structural sequential process, right? We've talked a little bit about food reactions, saying there's a standalone lesson on that. We talked about leaky gut. We talked about different types of gut infections and the testing methodologies. And I've just given you a very quick introduction to the gut-brain axis. What we're going to be talking about in our next session is what's called the 4R protocol. And I'll explain briefly what the R's stand for, but I will tell you that the 4R protocol has been around for a very long time, predates even me. And it's practiced or applied different ways by different doctors, just depending on how they're looking at a situation or what they see works in their practice. But these are what the R's stand for. The first R stands for remove. That means we got to get rid of critters. Second R stands for replace, and that means we might have to replace lost digestive capacity or some of the other compounds that are not being produced the way that they should. The third R stands for replenish, and that typically means the probiotic environment, the healthy bacteria. And the fourth R stands for repair, and that specifically relates to repairing a leaky gut if it's there or if we suspect and assume it is. So that's it for today. Again, it's a lot, so please, you're welcome to go back and listen to the video again. The next session will be going into the 4R protocol. We'll talk to you again real soon.